Good afternoon and welcome to the second session of No Pause in Menopause. Today we're going to talk about sleep, brain fog, and mental health, how menopause affects your brain and what women can do. And if you missed our first session on menopause basics, Menopause 101, you can check it out. Check out the video at our website, healthywomen.org. While you're there, register for our next few sessions. Helping Women has been around for more than 30 years. And what we've been doing and what we do really well is creating information, resources to educate you about your health. Everything is based on evidence-based research, so you know you can trust it. And besides great education information, we provide you with the resources that can help you make educated decisions about your health. We all know that the years leading up to menopause and the transition itself can bring changes to your physical health. But did you know it can also affect your mental health? We're going to find out more about that today. Shifts in levels of hormones can cause mood changes, but it also can affect our sleep. It can affect our brain as well as overall mental health. Now, pepper stress and anxiety onto that. Stress and anxiety intensifies and amplifies the symptoms of menopause. So just think about this year in COVID-19 and what many women are experiencing, not only going through menopause, but the additional of stress and anxiety that COVID-19 has been put on all of our shoulders. But there's answers. There's answers to your questions. And today we've got a great panel of experts that are going to provide some answers and more information on how menopause can affect our mental health. Today, I'm so pleased to introduce Sybil Amudi, who is going to be talking to all of you and moderating today's session on No Pause in Menopause, how it affects our mental health. Sybil is the producer and the host of the Great Girlfriend Show, a podcast series created to connect women with daily tips and solutions for living passionate everyday life and building a thriving business. Healthy Women partner with the Great Girlfriend Show to bring many of our conversations on health topics to our shared audiences. Sybil is also a philanthropist and is so passionate about youth mentorship and eradicating hunger and educational girls in the world. We are so fortunate to have Sybil moderating this conversation. And now I'm going to turn it over to Sybil to introduce our amazing panelists. So Sybil, I'm turning it over to you.
Awesome. Thank you so much, Beth. I am so happy and grateful to be here today. Wow, Healthy Women, you do a fantastic job of bridging the conversations that are essential to our mental health and our wellness around all topics, and especially menopause today, which is not an if, but it is a when conversation. So we're in great hands today because we are being connected with women who are leading the industry in these topics. And I want to introduce to you our three panelists for today. We'll start with Dr. Gayatri Devi, who is an attending physician at Lenox Hill Hospital, Northwell Health, and clinical professor of neurology at Downstate Medical Center. Focused on promoting brain health, she established her premier center for neurologic wellness, education, and research in 1999. Dr. Devi is board certified in neurology, pain medicine, psychiatry, brain injury medicine, and behavioral neurology. Widely published, Dr. Devi's research focuses on the optimal treatment of stroke, cognitive loss, and pain. Featured on the BBC, CBS, New York Times, NPR, Time, and Wall Street Journal, Dr. Devi has authored several books, most recently, Spectrum of Hope, an optimistic and new approach to Alzheimer's disease and other dementias. She is neurologic consultant to the New York State Committee for Physician Health and the NFL Players Association, and is on the board of overseers of SPS at Columbia University. Dr. Devi loves NYC, her home for over 30 years, and is an NYC Parks Enforcement Patrol Mounted Auxiliary. Welcome, Dr. Devi.
Thank you for having me. It's such a joy to be here with all of you women. It's a fabulous opportunity.
We're gonna get all into your brain today, if that's okay. That's your specialty. We're gonna dive in.
forward to it.
Awesome. And then we have Miss Anne Garnier, who's founder and CEO of Lisa Health. She is a seasoned healthcare leader helping to create, launch, and scale innovate tech companies and products that have improved patient outcomes and access to care. At Lisa Health, Anne leads the team to enhance the well-being of midlife women starting with menopause transition. She is passionate about women's health and advancing research beyond pregnancy and fertility to reduce the serious and costly health risks that women face as they age and help them celebrate the start of something great. That is so good. Anne sits on the advisory boards for Femtech Collective and the Healthcare Businesswomen's Association Bay Area chapter. She is also a C-Sweetener mentor and an ambassador for Annie Cannons. Welcome, Anne Garnier. We're so happy to have you today.
Thrilled to be here on the Healthy Women panel. Thank you so much for having me.
Yes, and I see there's a lot of advocacy there. So we're incredibly excited to include that perspective into this conversation. And last but not least, we have Dr. Pauline M. Mackey, a professor of psychiatry, psychology, and obstetrics and gynecology, and associate dean for faculty affairs at the University of Illinois at Chicago. She also serves as senior director of research at the UIC Center for Research on Women and Gender. For the past 25 years, Dr. Mackey has led a program of NIH-funded research on women, cognition, mood, and dementia, with a particular focus on menopause. She won the 2018 Women in Science Award from the American Medical Women's Association and the Thomas B. Clarkson Outstanding Clinical and Basic Science Research Award from the North American Menopause Society. She has won a number of NIH awards for her research and service, serves as a research and career mentor to many students and junior faculty, serves on executive committees for several women's health advisory boards, and is a frequent international and national speaker. Welcome, Dr. Mackey. A pleasure to speak with you as well today.
Thank you. It's a pleasure to be here.
So for anyone who's watching and you have questions about menopause, we want to take all of your questions today. We're asking that you drop your emotions, your thoughts, your questions into the chat, because this conversation is for you. It is here to serve your journey, and it's here for us to take copious notes so that we can be prepared for what's ahead or whatever we're already facing. So I want to start by getting into your personal menopause journey. Is it okay if I start with you, Dr. Mackey?
Sure, that's fine.
Just if you wouldn't mind just sharing us one thing you learned on your personal menopause journey.
Well, it's funny that you should ask me that, because I've actually published in the Green Journal, the main journal of the American Obstetrics and Gynecology College, my own personal experience of having studied Imagine memory and menopause since I was 25, so more than half my life ago. And the experience that I relay there is what might be a common one to people in the audience, which is the I don't remember where I parked my car phenomenon. And I was explaining, based on the research that I've been fortunate enough to do over the past 25 years, that I now kind of understand what's going on in my brain when I can't remember where I parked the car, and that it's really not a memory error. It's that I wasn't paying attention when I was parking my car. So I never put that information into my memory. Why? Because like many of the women in the audience, I'm a busy woman who's constantly juggling things. And I was safely, hands-free, discussing a grant while pulling everything out of my car and then walking away. And I thought, you know, I might blame it on menopause when in fact, it's really my busy lifestyle that led to my inability to remember where I parked that car. It's not to say that menopause doesn't affect our memory. It's just that sometimes it's just life.
Nice. Oh, that's a good one. I love that. Brain fog is a real situation. Dr. Debbie, would you mind sharing with us a piece from your personal experience with menopause?
So actually, I'm glad Pauline brought up the article that was published, that she published about her experience in the Journal of the American College of Obstetrics and Gynecology, because it was in response to an article that I'd written there on two women in my practice who were misdiagnosed, one of them with Alzheimer's disease. The other was a woman in her 50s who was misdiagnosed with frontotemporal dementia, which are two fairly serious, significant illnesses. And one of them had had a very thorough workup in a very well-regarded memory disorder center, But unfortunately, no one had thought ever once in her voluminous chart to ask her if she had if she was going through menopause. No one had noted that she was on hormone medications for treating her menopause, and no one kind of put this chronology of the fact that she was beginning to have memory problems in her 40s around the time that she was going through menopause, and that then she began progressively to have trouble functioning, and it was related perhaps to menopause as opposed to what they ended up calling Alzheimer's disease. And the sad fact with this woman was that even though I was eventually able to disprove the diagnosis of the Alzheimer's disease and be able to say that this likely was related to the menopause that she was going through, the low levels of estrogen, as well as some depression that she may be having around the time of a menopause, she no longer had the confidence to go back to work. So I find that this is an area that's under-recognized, the cognitive changes in menopause, that anywhere from 30 to 62% of women going through menopause have memory loss. And while we're well aware of changes related to, say, hot flashes and night sweats, and even perhaps mood changes, we're not as aware of the cognitive changes that are related to menopause. And they can be very troubling, especially when they're misdiagnosed, as was the case in these two women.
Wow. For those of you that are with us today, if you've experienced that brain fog or that memory loss, we'd love to know from you in the chat if that's part of your experience. I can actually relate. My mom went through it and I didn't know what she was going through. Now I'm understanding so much more just talking to the two of you. And Anne, I want to bring this over to you and ask you also to share a piece from your personal menopause journey.
Sure. So as the non-clinician on the panel, the person who's always focused on technology, I have, a perspective that sort of dovetails with theirs, but maybe is slightly different. During my own menopause journey, I experienced firsthand the symptoms like brain fog and anxiety. But I also experienced, the lack of support and solutions for, what is really such a pivotal and complex life stage that every woman's going to experience. And it was very disconcerting to me because I'm used to being, very high achieving, on top of everything, juggling a million things. And so it was like this out of body experience. And, because I wasn't getting good support, I thought, well, I develop healthcare products for a living. I've been doing it for several decades. And so I just, kind of took charge of my own situation and did a deep dive into the literature and talked to, many experts and researchers in the field. And so with an N of 1, I started to, apply a variety of evidence-based, mainly lifestyle interventions, and had success with that. So I sort of had this light bulb moment and thought, virtually every other area of healthcare is leveraging advanced technology to improve outcomes. And, why should menopause be an exception? It basically leaves 1 billion women, around the world left to figure things out on their own. So that's why I decided to start Lisa Health. It really became my passion to empower women to thrive in midlife, starting with menopause and really harnessing that power of technology and evidence-based medicine. From my perspective, it wasn't just a matter of trying to eliminate the shame and silence around menopause, but there is a gap in care. And so I think it's important for us to be able to bridge that gap with technology and deliver, personalized, data-driven insights and therapeutics to women.
Very good, very good. So we've got some questions that we've prepared, but there are also questions coming in, and brain fog is leading the trend right now. So I think many of us are like, brain fog, what? And yes, this is real. Okay, the brain fog, is it permanent? Does it go away? How can we eliminate? Dr. Debbie, I'd like to start with you on this. Just walk us through that.
All right, so I actually want to tell you that I see quite a few patients with memory problems related to menopause in my practice. And I started because about 20 years ago, I saw a woman in her 50s who was having memory problems who came from a South American country, and it sounded like Alzheimer's. She was having trouble with her short-term memory. She was having trouble finding words. She used to be the world's best multitasker. She ran a large estate, and she found that now she couldn't really figure it out. She said that she became much more irritable. And all these features, short-term memory loss, trouble finding words, trouble with executive function, trouble with mood, all of these can be early signs of Alzheimer's disease too. And so at that time, I was part of a large university setting where we were looking at patients in this very methodical fashion. And we evaluated her and decided that she had Alzheimer's disease. And then because at that time there was a study where they found that if you put patients with Alzheimer's on estrogen, it delayed placement to nursing home. I put this woman on estrogen, not because I thought she had memory loss due to menopause, but because I thought that it would help her Alzheimer's disease. Well, she came back 6 months later and she said to me, you know, Dr. Debbie, I'm completely cured. And I said, well, that can't be. Well, when we did her testing, we found that in fact, her cognitive deficits had improved substantially, and she no longer fit the criterion for dementia or Alzheimer's disease. And that's what got me started thinking on the path of what was it? Why is it that this woman got better? Clearly, I had made the wrong diagnosis. We had made the wrong diagnosis from our university environment, and perhaps there was something else going on. And since then, I've discovered that there's a whole body of literature. Barbara Sherwin at McGill University was the first one to describe this, that in women who've had surgical menopause, immediately afterwards, they have trouble finding words. Surgical menopause is when you have your ovaries removed from a hysterectomy. And they have trouble finding words. They have short-term memory loss. They have trouble multitasking. All of these different changes that resemble very much early Alzheimer's disease. And so subsequently, I started seeing many women in my practice because that became my specialty. I wrote a book on it. And I would see particularly working women, women who are at the peak of their professional careers, women in their late 40s, early 50s, who had gotten to where they were because of their ability to articulate, right? Women are verbal people. We're not grunting people. You know, we talk and we get to where we are, and suddenly we find that the very words that helped us get to where we were are now failing us. We start saying carpooing the champette instead of shampooing the carpet. We start to misplace things. And at the same time, as Pauline mentioned, there is a lot of life changes. We become very busy. We're taking care of our children who are growing up, perhaps they're teenagers, and we're taking care of our older parents who may have their own issues with cognitive problems. So suddenly, in the midst of all that stress, your brain starts to fail you. It's a very scary thing. So one of my areas that I'm trying to focus on, and one reason I'm so happy to be on this panel, is because I want people to be aware that there is this memory loss that's documented, that's objective, that can be found on testing, that looks like early Alzheimer's, that's related to menopause, and that can be treated. Some women respond to hormones. Some women don't like hormones, and we did an early study where we looked at using certain medications that are not hormone related that seem to have benefit in women with menopause related cognitive loss. We've also found that brain exercises can be helpful in women to help them with their cognitive loss. So there are other ways to address it. We still don't yet know, I think, really what happens to women who have cognitive loss in menopause 20 years down the road. We don't know. We do know that most women do get better with help, and sometimes even without help, because our brains are incredibly resilient.
Got you. So what I'm hearing you say is there's hope.
Oh yes, absolutely.
It's a real thing. So for those of us that are questioning and asking, is this real? Does it last? It doesn't have to last, but we do have to be willing to ask the right questions when we are with our physicians, and open up to the idea that, you know, the pain that we are sometimes normalizing needs attention. So I want to come over to you and talk about that, some of the advocacy when we do need to ask those questions, and, you know, make sure that we're bringing these things to our physicians' attention. What are some of the things, Anne, that you think we should attend or kind of bring to the surface as we prepare to go to our doctors?
Sure. So, it's well known that, only about 20% of physicians are trained in menopausal care. So as I mentioned earlier, very often women aren't getting the support and they're turning to unreliable sources like Dr. Google and Facebook. We had a conversation before we joined the panel about social media, influencing perceptions of menopause. So, what I always recommend to women is that if you are not getting the support you need from your clinician, find another one who does have a competency in menopausal care. The North American Menopause Society has an online directory of clinicians who are certified in menopause care. And so don't give up, keep trying, find that clinician who is really going to listen to you and support you. You do need to be your own advocate, but I would also add, try to support your partner or someone you're close to in your advocacy if you feel like you need additional support. So engage in conversations with the people closest to you. Again, your partner, children, even parents, and explain to them what's happening, how you're feeling, and ask them to support you in getting the help you need.
Mm-hmm. Really good, really good. And I'm wondering, when I think about things that could help boost cognition, Dr. Mackey, are there any foods or vitamins that we could probably just incorporate into or integrate into our diets or regimens to help really boost cognition?
So diet and lifestyle factors are key to maintaining our brain health, not just at menopause, but also thereafter. One of the rather easy to engage in diets is the Mediterranean diet. And there's very, very solid evidence from very large randomized trials that the more of the Mediterranean diet that you incorporate in your life, the better your brain health. In fact, it prevented preclinical Alzheimer's disease in a large clinical trial. So we all might have a hard time maintaining the Mediterranean diet, which is not a lot of red meat, lots of fish, lots of lentils, vegetables, olive oil, thankfully a little red wine, which we all enjoy. All of this is good for our brains. Now, we don't have to change every meal. We can just opt for the hummus and carrots instead of the processed donut or whatever we might typically reach for. So Mediterranean diet is very good. Vitamins generally, there's not a lot of evidence to support that, but some women are deficient in vitamin B12, and for them, their cognitive problems could be tied to B12. Some women have anemia, and that can contribute to memory dysfunction as well. But lifestyle-wise, the thing that's really important is brisk exercise, getting our heart rate up. You don't have to run a marathon. You can walk briskly for an hour, 4 times a week. If you're busy, like 99% of the women probably here, you can break up your exercise into multiple subcomponents. So you walk for 10 minutes, at 10 a.m. and then another 10 minutes at noon. Research shows that that still promotes very good brain health. We want to decrease our alcohol intake. Remember, for women, it's 1 to 2 glasses of wine is just the right amount. More than that actually can cascade into cognitive difficulties, as well as mood difficulties. And interestingly, we know that when women's estrogen levels are changing during the menopause, they're even more sensitive to the negative effects of alcohol. So it's really important that women rein that in, which is an easy to go to coping mechanism, isn't it, after work to grab that glass of wine. So that's something that women can avoid as well. Hitting the books is always good. Doing something new for your brain, learning a new language, something that you're not expert in is the key to exercising your brain. You want to do something novel. So the good news is that there's a whole heck of a lot we can do. In addition, we want to keep our hearts very healthy. We want to make sure that we treat hypertension. We want to keep our cholesterol levels in check. And then, of course, sleep is a main one, right? So there are changes with sleep, and I think we'll come to that topic perhaps later. But it's a multi-pronged approach, and the Alzheimer's literature shows that the more of these approaches that you use, so if you do more of the Mediterranean diet and you engage in more exercise, that they combine together to promote a healthier brain. It's actually estimated that 70% of Alzheimer's cases could be prevented or delayed, I should say, if people engage in these lifestyle factors, which is good because it's empowering women to maintain their brain health as they age.
Wow, that is so powerful. Oh my goodness, note upon note upon note of things that we can do to help reduce, I guess, the symptoms or reduce some of the pain of going through menopause. And I also want to lean into depression, anxiety, and mental health, because those factors I think are just as equal, right? In our brain fog and sleep and all these other things, the depression or the onset of depression is real. And so for those of you that are watching, we are curious if you can relate in any way, whether or not, depression, you have a correlation between depression and menopause. And I do want to stick with you, Dr. Mackey, and ask, what is it that causes the mood changes during menopause that, make us just feel, not ourselves?
Yeah.
Yeah.
Such an important question, isn't it? So there's really two types of mood problems, I think, that are of relevance to our discussion today. The worst kind are those that are what we would call clinical depression. So that's when mood symptoms are so serious that they affect your ability to carry out your activities of daily living, and those last about at least 2 weeks. Now, those are very serious mood changes. The research shows, and I was fortunate enough when I was president of the North American Menopause Society to co-lead the first guidelines for the treatment of perimenopausal depression. And this is where my comments come from, is very systematic reviews of the entire literature. It's actually women with a history of major depression that experience a recurrence of that clinical depression at the menopause. They're responsible for the large majority of that very serious clinical depression. And of course, we know that women are twice as likely as men to develop depression, in part due to our hormonal differences, right? And that's where postpartum depression comes in, and some changes in mood that can occur during the menstrual cycle. Okay, so that's the one hand. The clinical depression, that's really a period of vulnerability in the perimenopause for women who already have that history of depression. The second type is, I'm just not feeling as well as I normally do. I'm not absolutely depressed. I'm able to do my activities of daily living, but I just don't feel like me. I don't feel as happy. I don't feel as engaged. I don't find things as engaging. And it turns out that epidemiological studies show that this is really very, very normal in the menopausal transition. And it starts to occur when women's menstrual cycles start to change. And so that's the first hint that it's the variability in estrogen and progesterone levels that contribute to this disruption in mood. So there's very much a hormonal change. However, there are also other environmental triggers. Many women have hot flashes, and those hot flashes keep them up at night. And what's our mood like when we don't sleep well? And what's our mood like when we don't sleep well every night for many nights, right? So some of the symptoms of the menopause itself, the cardinal hot flash symptom experienced by 75% of women, can cause depression by infusing this kind of sleep cascade. So this problem with sleep. So it's really important that women talk to their provider, preferably a NAM certified menopause practitioner, like Anne mentioned earlier. Thank you very much. So that they can guide women through that very important discussion about hormone therapy, also for their hot flashes, and in that way it can contribute to improved mood. However, even in women without the hot flashes, research by Claudio Suarez and Haydeen Jaffe shows that estrogen can be very good for mood, but only in the perimenopause. In the postmenopause, estrogen is no longer any good. So it's a combination of menopausal symptoms and hormones that contribute to mood disruptions in the perimenopause.
That's an interesting bridge into this question here from an attendee that says, I've noticed dramatic changes in my sense of smell, much more sensitive recently. Is this a symptom of perimenopause? I also noticed it during pregnancy, so wondering if it's hormone related. Sense of smell, that's a new, listen, all of this is very new to me. I'm learning as we go, but that one is one I've never heard. So I'm curious, I'll start with you, Dr. Debbie. Is that one that you're familiar with, a loss of sense of smell or changes in sense of smell and in relationship with perimenopause?
Generally not. I mean, I see a lot of women going through menopause who come to me for neurologic problems. So I see people who have sudden changes in their migraines. I've had people who have new onset migraines. I have people who have new kinds of movement changes that they didn't have prior to going through perimenopause. Change in sense of smell, not so much. Although I know that when women go through perimenopause and menopause and they're experiencing these cognitive changes, and they may look it up with Dr. Google, as Anne mentioned, they may then come across changes in sense of smell as one of the symptoms of one of the early symptoms of some types of dementia. And so that may be a concern. But generally, change in sense of smell is not a big complaint in my patients.
That's really good to know. And I also want to go into this one with you, Anne, because we are, like you said, we run to Dr. Google, we run to Facebook, and we also run to our friends. And they tend to be our leading doctors and clinicians, and they can guide us, anywhere, to the right or to the wrong places. I know that, as you mentioned, there are a limited number of menopause specialists. And so I'm curious, where do we start our journey, and how do we make sure that we're on the right path so we are seeing the right physicians?
Sure. So, what you need to understand is that, at least from my perspective, every menopause journey is unique. I always say it's like a fingerprint or a snowflake. And so what works for, one woman in your circle, or somebody you've seen post on a Facebook page, may not work for you. And I feel like women do go through this, years-long cycle of trial and error, just trying all these different things, spending a lot of money on things that, don't work or don't work for them and may in fact be harmful. So I do think it's important to have that persistence around, finding a clinician who is trained in menopause, or at least a physician who is willing to sit and listen to what's happening and really help you sort of unpack and sort of decode your symptomatology so that you can have this shared decision making with a clinician around the options that may be right for you, whether that is some prescription based medication, or getting a referral to a specialist like Dr. Debbie or Dr. Mackey, or engaging in evidence-based lifestyle activities. I mean, lifestyle interventions will never hurt. They will only help your health and well-being, and they could actually give you even that little bit of boost you need to start to feel more activated around taking charge of this phase of your life. I think some women, because of the mood issues they're experiencing, they really have trouble with the motivation almost to be able to get the help that they need.
So I think one of my learnings, and even a question I'm seeing in high frequency, is a question of menopause competency in gynecologists, whether or not, all doctors, I'm basically hearing from you that not all doctors share the expertise or knowledge. So what is it that we should look for if we want to find a doctor who is knowledgeable in this area? And I'll start with you, Anne, if you have any ideas of just some of the things that you've learned from your experience, and then Dr. Mackey, we'll move over to you.
Sure. So again, there is a certification through the North American Menopause Society, and they do have an online directory. So I think that's a good place to start. But I know that maybe those individuals aren't, readily accessible in your area for an in-person visit. The good news is that, many, health organizations have started to offer telehealth because of COVID. So you may actually be able to access some of those experts through a telehealth visit. It's not a substitute for an in-person visit, but given where we're at with the pandemic, it's better to at least get that online visit than to not get help at all.
Very good. Dr. Mackey, anything
Yeah.
that we should know or ask when we're looking for someone who is certified and highly competent?
I think Ann has said it exactly. Somebody asked, why don't all OBGYNs know this? You know, they used to. Prior to the Women's Health Initiative, training in menopause was ubiquitous. Everybody got it. All these OBGYNs got training in menopause. And then in 2002, when the results of this large randomized trial called the Women's Health Initiative were published, enthusiasm for hormone therapy greatly decreased because of what we now know were kind of overblown concerns about the harms of hormone therapy, at least for younger women. And as a result, there was just no more training in menopause. And in fact, we've lost almost 2 decades of trainees in this very important topic. And there was an editorial in JAMA by Joanne Manson, one of the leaders of the Women's Health Initiative, saying, you know, we really need to train our medical students and our residents better in menopause, because as you said, Sybil, this is 100% of women. We all go through this, right? They get more training in things that affect less than 1% of the population than they do in something that affects 100% of the population. So, you know, it's a great disservice to women. And I think that with hope, one of the silver linings in this terrible pandemic is that these telehealth services by the experts who we do have become more readily available to women, and make women call for this. They want informed information about this by people who've been trained in it.
That is really good, Dr. Mackey. There's an awesome benefit that we do have right now is the reach of telehealth and being able to, not be worried about going into an office because the hours are more readily accessible to us and people through through our Dr. Google. So we're able to use Google for our advantage in our health journey. There is this big monster, and it's running all through our Q&A, and it's running through our chat that we haven't attacked. Dr. Debbie, I'm going to give you the monster. It is sleep, or the lack thereof. What we're hearing, and from many women here in the chat, and also we'd like to know from you if you have experienced change in your sleep habits, or you've heard that from your friends that maybe they're experiencing disruption in their sleep habits as a result of menopause. We all know that can affect your day, it affects your mood, affects everything. So I'd love for you to kind of, not necessarily tackle the whole monster, but give us a bit of insight into sleep and the relationship between sleep and menopause. And then what can we do to offset, the effects of lack of sleep, or even make it better?
So women going through menopause have a lot of deterrence to sleep. They have the hot flashes. They have the night sweats where they wake up with their clothes completely soaked. And so they're going through a transition where consistent, uninterrupted sleep really becomes difficult. Sleep is very important for us to rehearse our memories for the day in our dreams during our slow wave sleep. Sleep has a specific architecture with slow wave sleep, REM sleep, different stages of sleep, and that gets repeated through the night. And that architecture of sleep gets disrupted by the changes of menopause. What it does then is it then interferes with our ability to remember things, because when we sleep, we actually rehearse the events of the day and remember things better. So what your grandmother told you, which is to sleep before an exam so you'll do better on the exam, is actually completely true. So it's very important the next day for your functioning, because it affects multitude of things. First of all, if you sleep well the night before, you're better able to remember the events of the day before. If you sleep well, you're also better able to eat more healthy, because if you don't sleep well, a lot of times we actually tend to put on weight because we eat differently from when we have a good night's sleep. The levels of leptin and all the hormones are much more in regulation. When we don't sleep well, we also become very irritable, and irritability combined with when you're trying to remember something and someone interrupts you, you're going to snap at that person. When you're having trouble with your memory and someone interrupts you, you're going to snap. So one patient told me, she said, you know, my son's calling me the Tasmanian devil right now because I've become so irritable. So irritability and mood changes are also occur as a result of trouble with sleeping. Another problem that happens in the menopausal transition is that some women put on weight. And the weight gain, especially abdominal weight gain, can also affect our sleep patterns because it can cause sleep disturbances as well. So that's another issue. So between the mood and the level of alertness, people often say to me, you know, I have trouble sleeping. They'll never say to me, I have trouble with the quality of my staying awake. So a lot of times when we have trouble sleeping, our daytime alertness, the quality of our daily awakeness is different. And when that happens, we're not paying more attention, we're not focusing on things better, we're not able to take in the information enough so that we can consolidate that memory and then retrieve it later when we need it. So those are all very important things. And hormones can help with sleep, and even in women who don't, you know, are worried about using hormones, there are other treatments that can be helpful for a better sleep, night's sleep. And what are some of those things? One of the most important things, and this is true for all of us, whether we're going through menopause, whether we're teenagers, whether we're older adults, is that in modern society, we have learned to think of sleep as a fungible space from which we can draw for being, you know, for social things, for work-related things, for anything. If we're time constrained, the bank that we think we can draw from is a sleep bank. So we will we'll use sleep as a space from which to remove time. And that is absolutely wrong, because we have to get back into the habit of basically elevating sleep to a very important level in our daily routine. Sleep is not a place that it's not a space that you disregard. Sleep is a space that you truly respect. And the idea of turning yourself on and turning yourself off like a motor has led to an epidemic of overprescribing of sleep medications in this country and around the world, as well as stimulants, medications to power ourselves back on. So we kind of have almost learning to think of ourselves as motors, turning ourselves on, turning ourselves off, but really we're not. We're organic beings that need to go into sleep and get up from sleep. And we're born experts. We're all experts at sleeping. We just have unlearned, many of us, how to sleep well. And during the menopausal transition, there are certain other events that make it much harder. So you can really get back into good sleep hygiene. One of the most important things I tell people is turn off your cell phones in the evening. Turn them off around 8 or 9 and leave them out of your bedroom. If you insist on having your cell phones in your bedroom, put on the blue light filter so that it's not daylight type light that you look at when you turn your phone back on. Try to read or listen to a podcast or something like that if you really need to have something to help you go to sleep. And then exercise. Physical exercise actually is very helpful in helping us get into a relaxed state to go to sleep. So those are some thoughts I have. I'm not a big fan of the use of medications to help us sleep.
Mm-hmm. Wow. Well, you know what, to be quite honest, Dr. Debbie, if we did one of those three, I'm sure many of us would experience much better sleep than we have. So those were such powerful tips. And I love how you talked about the respect for sleep. That is so important. And that we don't need to ask these questions. We just need to lean into the knowledge we do have about sleep, and then incorporate those solutions. Very powerful. Thank you so much. I could keep the three of you all day, but I know I can't. I know you have great work to do. So I want to touch on a couple more things, and there are more sessions. So for those of you that are watching that have a million questions, as I do, and really want to take advantage of all of these solutions, there are other sessions that are being offered throughout the day. Throughout the week, excuse me. You do want to make sure you're registered. So after this session, you're going to run over to healthywomen.org and register. But we're going to get back into our panel because I want to talk about technology. And how technology is playing a bigger role in midlife health. And Anne, I'd love if you kind of give us, the ways that you see technology sort of innovating this journey for us as women.
Sure. So, I think what we've sort of alluded to is that, it's hard to decode some of the symptomatology and figure out which symptoms are driving other symptoms. So the example that Drs. Mackey and Dr. Devi gave around hot flashes and night sweats really impacting your sleep, which then makes you tired, which then, potentially makes you eat less healthfully, you're gaining weight. So I think women really struggle to understand how all of the symptomatology interacts. And I think technology like artificial intelligence has the ability to sort of break that down in a very simple way and reveal that to women. Here is your unique symptom patterns. And here then are the evidence-based therapeutics that may work for you. And again, we have the opportunity to really personalize and have data-driven insights and therapeutics that are evidence-based. I'm not suggesting that we disintermediate the physicians in this conversation. I actually think it's very important. But all the physicians I've talked with, whether they're experts in menopausal care or physicians who don't know a lot about menopause, they all say that they would love if they had more data. And so, women coming in and being able to share data, share the patterns, show them the interventions that they have tried, what's working, what's not working. Technology can really provide that picture both to women and clinicians. And I think it's very powerful and really a game changer. As I mentioned at the start of the panel, technology in healthcare is, so ubiquitous, but menopause is really lagging behind. And again, because it is a life stage, a complex one that is going to happen to every single woman, I really think that we do need to have more support and focus on how we can harness the power of advanced technology.
Mm-hmm. Mm-hmm. Very true. Very, very true. And I thank you for being a part of that work because we need to have that advocacy in technology. And we do know that, having women in the room and at the table will help to support those needs as we journey. So thank you so much for that. We have another giant that has come up, obviously, with the question about menopause is hormone treatments. And so I know we are at our close of our panel, but Dr. Mackey, really quickly kind of talk us through to do or not to do hormone treatments. And how do you know if you are a good candidate for hormone treatments?
Such an important question. And there's a lot of misinformation and a lot of legacy from the randomized trial that I described, the Women's Health Initiative, and that led to a lot of misunderstanding about perhaps overblown risks. So let me start by saying that leading medical societies in the United States and around the globe published in 2015 what was called the Global Consensus Statement. And that said that for women between the ages of 50 and 60, the benefits of hormone therapy generally outweigh the risks, particularly for women who have vasomotor symptoms, hot flashes and night sweats. Mm-hmm. Nothing has the same effect on hot flashes and night sweats that hormone therapy does. I myself have done a lot of NIH-funded research on this. We've shown that hormone therapy will take away 98% of your hot flashes. And these are hot flashes that we measure objectively with novel technologies. So these are what we measure when women sleep. And it takes away 98% of those, which is, speaks to the power of it. Nothing else quite works that well. So particularly for women who have hot flashes, having this discussion with the physician is very important. Now, of course, if a woman is a smoker, if she is morbidly obese, if she has a family history of clotting disorders, if she has had a cardiovascular event, hormone therapy probably isn't the best thing for her. Organizations like the North American Menopause Society have reviewed the evidence for non-hormonal treatments, which again are nowhere near as effective as hormone therapy, but they do work, and they have patient handouts at menopause.org. Again, that's menopause.org for women who want that. Women are very afraid of breast cancer with hormone therapy. Just 2 years ago, they published the 18-year follow-up data from that big randomized study. and showed that actually women who were randomized to estrogen alone in that study after 18 years of follow-up had a reduced risk of breast cancer. And it was really the form of progesterone that they needed to take that was associated with that risk of breast cancer. There's a very rare risk of stroke with it, but in general, particularly for younger postmenopausal women who are healthy, the benefits seem to outweigh the risks. Again, its indication is for hot flashes, and those are the women who should take it. Those, Dr. Devi says, you know, this can be very helpful for women who are estrogen sensitive and who experience cognitive and mood problems at this time as well. So that's what we call an off-label use, but still evidence-based.
Thank you so much for that. And I know that we're going to get more into this topic of hormones and non-hormonal treatments in the session next week. But thank you so much for touching on that. I'd love to know in the chat from anyone who's had treatment, any of the things that you've seen benefit in, or if you were scared of treatment, we're just curious. And we also want to just kind of talk about menopause and work, right? Because not only is menopause, you know, and work and family, menopause is a complex topic for women. It's an intimate journey, but we all, like you said, 100% of women will experience this journey. You know, how can we have that conversation do we have the conversation at work? Do we make an announcement? You know, do we make an announcement to our family? And if we do have to, if we're at a point where we feel we need to have, you know, schedule or have transitions in our schedule, how do we communicate that? I'd start with you, Dr. Devi.
So Jane Brody wrote a whole piece about, you know, the article that was in the Journal of the American College on women with dementia. And what was interesting was the response of all women commenting on this article. And many women said, oh my God, let's not talk about women going through menopause with cognitive loss. As it is, women tend to have so many issues at the workplace, you know, with that glass ceiling and all of that. So why do we need to bring yet another factor in that allow men to say, oh, that's why she's behaving that way, she's going through menopause, you know? But yet we really need to make women aware. My advice to patients, because many of the patients who come to see me who are going through perimenopause and menopause and who are having cognitive changes are working women. My advice to them is, let's look at the data. Let's see where the areas that you are having trouble with cognitively. Let's see how we can figure this out, and let's see how we can treat it. I'm not necessarily sure you want to tell everybody about it, because then daily lapses, we all forget every day, whether we're menopausal women or non-menopausal andropausal men. Let's not forget that men also go through what's called andropause, where their testosterone levels go down and where they have trouble, cognitive difficulties also. So
on that.
Yeah, let's not forget. But so all of us forget. So if people start attributing just daily lapses or difficulties that we might have with finding words to, oh, that's because she's menopausal, then that becomes a problem. So I think, you know, going back actually to an earlier question you had, which is, which expert do you need to see? Yes, you need to see an expert who knows about menopause, but particularly you need to see someone who doesn't dismiss women, which is very important. I've seen cases where women with clear dementia have been dismissed as having hysteria because they are women. And it's less and less so, obviously, but if someone's going to actually listen to you and take your complaint seriously, that's the kind of physician or healthcare practitioner that you want to see, particularly, and if they don't have training in that area, they'll hopefully know how to get you to the right person. So very, very important to be careful about who you tell and how much you tell. And this is the same thing I tell to people with early dementia as well. You know, you can still have a very functional life, but just be circumspect about who you tell, because then you might get dismissed even more than you normally are just because you're a woman.
So good. Oh my goodness, so good. Okay, we're doing final takeaways. And I would love if you could leave our viewers and our listeners with one sentence of affirmation to help remind them of their power in this journey. Dr. Mackey, I'll start with you, and I'm going to circle back up to you, Dr. Devi, after Ann.
So I would say that memory changes at midlife in women transitioning through the menopause are normal. They're normal. You're not developing Alzheimer's disease. That's rare. 99.9% of women who experience this, it's not related to dementia, and it's likely temporary. So take heart, ride it through, and know that your friends are all there with you.
So good. Yeah.
Well, I echo Dr. Devi, you're not alone on your journey. I would love for women to celebrate Global Menopause Day by having at least one conversation about menopause and share your journey so that we can really, for once and for all, just bury the shame and silence around menopause and, get you the support that you need through this pivotal life stage.
Thank you so much. And Dr. Devi?
I say, don't have a healthcare practitioner who doesn't take you seriously. Anything that happens to you is something that's important and something that matters. And your practitioner needs to be your partner in helping you find the right solution for you. So never let anyone dismiss you.
Oh, that's so good. You all have left us with millions and millions upon millions of notes that we can take to prepare ourselves and our friends and advocate for ourselves in a new way and fresh way. So I want to thank you all for being a part of this conversation, for your contributions to the research and to the developments that are taking place for 100% of women. That is big. So it is very notable and important work. We want to thank you, Healthy Women, for inviting us to all come together in the name of this topic and really kind of celebrate and advocate in a new way and remind us that what is important to us is important, and we need to advocate in our doctors' appointments as well. And we also want to thank our sponsors and partners. We have Astellas and we have Genev for their support in this conversation. All of you participants who've been here and chatted and asked all the important questions, many of which we will be going over in our future sessions. We're also asking that you complete the poll and that you head over to healthywomen.org and sign up for more. There's so much more in store. And we want to thank you for being here with us today. Thank you so much.